Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
This program is presented by Medscape Education Global.
Hello everybody, my name is Alan Winston and I'm a clinical professor in HIV and genital urinary medicine at Imperial College London in the UK. So a warm welcome to this programme, which is entitled HIV, Inflammation and Clustered Comorbidities, Assessing Risks and Proactive Management. I have great pleasure introducing my two colleagues today, who are Giovanni Giraldi, who's a professor of infectious disease at the University of Modena and Reggio Emilia in Modena, Italy, and Sharon Walmsley, who is Professor of Medicine at the University of Toronto and co-chair of the Canadian HIV Trials Network. Welcome to you both, Giovanni and Sharon. Now, as an introduction, what is multimorbidity? Well, multimorbidity has different definitions in different healthcare settings and in different countries. I'm live in London in the UK, and this is the definition we have from the National Institute of Health and Care Excellence in the UK. And essentially, multimorbidity is defined as the presence of two or more long-term health conditions. This means that in somebody living with HIV, having one health condition, if they have one other health condition, they would meet this definition of multimorbidity. You can see on the slide here, it can be defined as physical or mental health conditions. And globally, the prevalence of multimorbidity is extremely high. It's around 30%, and as you would expect, it increases significantly with age, socioeconomic deprivation, and is almost universal as people get older. So, before we go any further, I want us to look at a lived experience, and we have a video from Esther who tells us about her lived experience in this short video.
Hello, my name is Esther. I'm a woman living with HIV in London. I'm an HIV advocate and a mentor mother who supports mothers living with HIV during pregnancy and beyond. My comorbidities were diagnosed through my general practitioner, that's my GP. And with time, the other diagnoses also came through, but most of my diagnoses have been through my general practitioner who does the referrals to a specialized clinic. I'm a woman living with HIV, and I also have neuropathy, which was diagnosed earlier on during my HIV diagnosis. I was also diagnosed with TB, which I later on recovered. I'm also living with high blood pressure on treatment, and recently diagnosed with diabetics and rheumatism. And I also have back pain, and I had a back surgery in 2019. And those are just some of my comorbidities. The impact they have in my life is quite a lot. I am a mother of two children who they are now adults, but earlier on in my life, it was quite challenging. As when I was diagnosed with HIV, I was also diagnosed with TB and neuropathy, which was quite severe, and it affected me deeply in terms of my mobility. I wasn't able to work or walk, so I needed a lot of support from friends and family to just help me with my daily activities. my main condition, which is HIV, is managed very well in an HIV setting and an HIV clinic, which coordinates very well in terms of my neuropathy and other, like my gastritis and other problems, and they manage it very well, and they are able to refer me in case there is an urgent referral or I need urgent care. For example, I just recently was referred to a hospital and to a neurological hospital for to have my back surgery, and it was quite difficult because the neurologist in this clinic didn't have enough information about my medication or what my CD4 count, for example. He didn't know what the difference between my viral load and my CD4 count. And just before my surgery, he mentioned like I had a high viral load, which I found that quite difficult. And I had to advocate for myself and say, no, I don't have a high viral load, but I have a high CD4 count and undetectable viral load. So I became an advocate for myself at that moment. I have received stigma, and I think stigma is around us every day in our life. For example, I was having had a toothache and I had an infection of the tooth, and I went to my local dental practice, who didn't offer me a tooth extraction, which was just a minor tooth extraction. It wasn't so bad because I had received my antibiotic and my tooth had healed, but he opted not to offer me this tooth extraction, and I was referred to a dental hospital to have it done, which took a long time, and my tooth got really bad. And this is a situation that could have been dealt with at the dentist. I think it's very important for clinicians to share, to learn. I think people living with HIV are continuing to be discriminated. There's a lot of misinformation and messaging around HIV and how it's transmitted. The nurses, the hospitals, they all need to have some sense of education in terms of HIV. Just for example, going to have a blood test at some point, the nurse would wear 2 or 3 gloves. I just find that is very odd because we're in 2024. HIV treatment is advanced. There's a message of U is equals to U, which is supposed to be knowledgeable to most clinicians and most nurses. We don't need to feel discriminated against ourselves in 2024. I think we have come from so far, and things need to change around the healthcare settings.
So I think we can see from Esther's experience on living with HIV and comorbidities and cluster comorbidities, some of the challenges that people face in recognizing these comorbidities, and also, and what's really important, is in navigating healthcare and explaining to physicians and healthcare professionals from different medical specialties her health, her comorbidities, and how they interact. So we've spoken until now about individual comorbidities, but there are different ways of looking at comorbidities, and one way is looking at how they naturally group together. In the UK and Ireland, for over a decade now, we've been running an aging study in people living with HIV and also in people who don't have HIV, called the POPPY study. And we've seen, as in many other studies, high rates of comorbidities in people with HIV. But some of the work we have done is to look at how these comorbidities cluster with each other. This slide is highlighting a principal component analysis of 6 patterns of comorbidities. And you can see there's natural clustering here. This is allowing the data to speak for itself and how these comorbidities go together. Here we see the actual different clusters of comorbidities. Now, some of these clusters you may expect. We know that for cardiovascular disease, we know if somebody has hypertension, they're more likely to develop cardiovascular disease. We know for sexually transmitted diseases that syphilis and gonorrhea tend to go together. But there are some of these clusters which are not as well established or reported as the first two clusters. And there are some of these clusters which differ in people living with HIV in the POPI cohort compared to the people who don't have HIV. There's a strong mental health cluster. We see a cancer cluster. We see a metabolic cluster. This is distinct from the cardiovascular cluster. And then there's this last cluster. This, I should say, is ongoing work, but we believe this cluster to be related to previous AIDS illnesses and pneumonias and predominantly be a respiratory cluster. So Sharon, can I hand over to you to talk about comorbidities within the Canadian cohorts?
Right. So thanks, Alan. So similarly in Canada, we have a cohort of older people living with HIV. It's called Change HIV, the Correlates of Healthy Aging in HIV. And in order to participate in this study, our persons are of age 65 years of age and older. And similar to what Alan has found in the UK, is as people have survived from HIV, they are suffering from many of the comorbidities that we see in the general population. And similarly to what's happening in POPI, we do see these clusters of disease related to the heart, disease related to the lungs, and the diseases related to other systems. And similarly to POPI, we have 78% of our cohort does meet the definition of multimorbidities. So this is certainly an issue that we deal with. And as many of you know, I've always had this gender bias, and it's really important that we look at health issues related to HIV in our women as well as men. And this is a study that we had done several years ago when we looked at women living in Ontario, which is one of the largest provinces in Canada. And we found, again, that women living with HIV have large numbers of comorbidities, and that the incidence of this cumulative comorbidity increased with age and was always higher than their HIV negative counterparts over time. We then went on to say, well, how does this comorbidity impact quality of life? And we did find that those individuals with multimorbidity had lower health-related quality of life. And I think we can all remark on Esther's journey and how her neuropathy and how her back pain and all these other elements of her comorbidity negatively impacted her life. But what we also found in this study is stigma continued to be very important. And I think Esther highlighted that very well, is that overriding comorbidity, HIV-related stigma, continues to be a problem for our patients.
Sharon, thank you very much. So Giovanni, can you elaborate on some of the roles you think may be underlying this and potentially the role of chronic inflammation in the pathogenesis of these cluster comorbidities in people with HIV?
Well, yes, Alan, we needed to recognize that there are a common pathogenetic pathway at the basis of many comorbidities. Well, we are used to divide risk factors related to the patient, to antiretroviral toxicity, and to HIV itself. But let me underline that, first of all, the risk factors related to the patient are really the drivers of many comorbidities. Let me quote, for instance, smoking play a major role. And we know that smoking habits, it's definitely more prevalent in people living with HIV. But given that, let me concentrate to the HIV-related factors. This factors is really related to the excess in systemic inflammation that, as you said, is the driver of many comorbidities. Well, inflammation is increased in people living with HIV, and it's still difficult to measure it with serum biomarkers. But we know inflammation comes really from tissue. And actually, this tissue is ectopic fat. We know that any fat that is outside the subcute area, I mean, for instance, the fat that is present in the liver, the fat that is present in the epicardial area, or most of all, the visceral fat. Well, this is a different tissue. This is, in fact, an endocrine tissue that is able to produce inflammatory cytokine. We know that the fat cells are different. We know that the fat cell, in fact, are able to produce inflammatory cytokine that are related to atherogenic dyslipidemia, to insulin resistance, to a prothrombotic state, and in fact, that increase inflammatory biomarkers. And so this is interesting because you see, it's difficult to measure circulating factors that are associated with inflammation, but in fact, we can measure the fat tissue in ectopic area. For instance, something that is very easy to measure nowadays with FibroScan is the amount of fat that is present in the liver. And we know that this that we call hepatic steatosis correlate very well with single comorbidities, with multimorbidities, and also with cancer and the geriatric syndrome and frailty as a whole. And so actually, I think that inflammation is really what drives comorbidities and frailty, and altogether what drives the aging issue in people living with HIV. That is why now we call meta-inflammation and we call inflammaging the process in which inflammation drives the aging process. Well, I would like to introduce a new concept that nowadays is turning to be more popular in the HIV literature. So far, we've concentrated on metabolic diseases. Actually, we built also a construct just to depict a phenotype of people at increased risk of cardiometabolic condition. We called that the metabolic syndrome. But let us put this in a different context in which we try to put the patient at the center of all this. And nowadays, we try to say it in a different way, in a different perspective. That is, can we describe a metabolic issue in the context of health, not just of disease? That is why now we consider the metabolic health rather as, let us say, not just as an absence of metabolic disease, but rather a roadmap for healthy living. And actually this put the patient at the center and put the lifestyle of the patient at the center of intervention. Well, definitely we still need to recognize that there are metabolic parameters that need to be collected. First of all, BMI, that is the body weight, the visceral and liver fat accumulation, of course, the lipid fraction, glucose, and insulin resistance, but also bone turnover and also kidney function altogether. You see, considering metabolic health is really to consider the way in which we can improve the health of individual, improving the metabolic pathway. And so, you see, if there is an increased inflammation, the best way in which we can reduce this inflammation is to improve the metabolic parameters, because we know that inflammation comes from metabolic abnormalities, and if we are able to reduce the metabolic the arrangement, we will also be able to reduce the inflammatory process. Let me quote two studies that in fact have changed somehow the view about metabolic diseases in people living with HIV. The first is the Reprieve study, and definitely we were impressed on the fact that statin were able to reduce by 35% the cardiovascular event, but even more, we were able to reduce by 21% the composite endpoint of cardiovascular and mortality. And somehow what was found in this study that there was an excess benefit of statin that not just reduced by 30% the lipid level, but actually the impact that they were able to show was furthermore as if we were able to reduce by 80% the lipid level. And so somehow it addressed the fact that statin may in fact reduce some inflammatory pathway in people living with HIV. And because of that, not just reduce only cardiovascular risk, but also reduce the overall mortality in people living with HIV. Let me address a second study, which I believe is as well as important. And actually, this is interesting because semaglutide was able to reduce by 10% BMI, but actually was able to reduce by 30% visceral adipose tissue. And in fact, we were able to prove that this reduction in visceral adipose tissue was able to reduce by 40%, for instance, high sensitivity CRP, or by 20% IL-6, that are the two most important biomarkers of inflammation. And so again, addressing metabolic diseases and addressing fat in the visceral area, we are able to reduce inflammation and hopefully to reduce comorbidities and multimorbidity.
Yeah, so Giovanni, there are other groups that have been trying to look at other ways by which we might decrease this inflammation that may be contributing to comorbidity in people living with HIV. And one of the concerns is that many people with HIV have asymptomatic CMV infection, and that perhaps reactivation of CMV or CMV in some way is causing an upregulation of the inflammatory markers. And so there was some early studies in vitro done with this drug called letermovir. And what they were able to show is that it was able to decrease some of the proteins or inflammatory markers that were linked to cardiovascular events. And this drug was safe, it doesn't have any adverse events, and is capable of suppressing CMV shedding. And so there was an ACTG trial that was initiated with a plan to enroll 180 persons living with HIV with HIV suppression on antiretroviral therapy compared to standard of care, with the primary endpoints of some inflammatory markers, including plasma ST and FR2, other inflammation and cardiometabolic indices. Unfortunately, however, this study is currently on hold because unexpectedly there was an increase in the plasma inflammatory marker, which we still don't understand and is a source of ongoing investigation. But as you talked about before, there are things that we need to consider other than decreasing inflammatory markers to try and decrease these comorbidities. And this is old data from the DAD study that showed the impact of smoking. And clearly, as we all know, if somebody is a smoker, they have an increased risk of cardiovascular disease. And in the DAD study, they were able to show that with progressive years of stopping smoking, that cardiovascular risk decreased. And as Giovanni alluded to earlier, the incidence of smoking in the HIV-infected population is much higher than that of the general population. So this is clearly an intervention that may help decrease comorbidity. And furthermore, as Giovanni outlined as well, increasingly we are finding that NASH or NAFL, or fatty liver disease, is another important cause of comorbidity. And in the past, although most of our liver disease in people living with HIV was related to hepatitis B and hepatitis C, we now find that fatty infiltration of the liver is increasingly a cause of hepatic morbidity and mortality. And this is data from a Medicare recipient study in the United States that showed of 2,800 deaths, that 34% of them were related to liver disease. And of this, only half was hepatitis C, whereas 20% was due to NAFL, 14% to hepatitis B, 11% to combined viral infection, and 4% to other causes. And again, I get back on the gender issue. When we think about cardiovascular disease, we usually think about men. And as Giovanni alluded to before, the REPRIEVE study showed us that the use of statins can decrease the incidence of cardiovascular and cerebral vascular disease. And this was pronounced not only in men, but also in women. And much to many people's surprise, the incidence of cardiovascular events in this study was in fact higher in women than in men.
Thank you, Sharon, and thank you, Giovanni. Now, one of the challenges or one of the difficulties we have in clinic we know these comorbidities exist and we know these clusters exist. But using tools to assess the risk of these comorbidities have tended to be individual tools. But there are now some combined assessment tools. This is the University of Liverpool Combined Comorbidity Calculator. And what this calculator does is it takes validated screening algorithms and tools, but it puts them all together with calculators like this. You can look at cardiovascular health, the Framingham score you can see is here, the Haas bleeding score. There is a atrial fibrillation, the CHAD-S score. There's a renal equation. There's a FRAC score for bone health, and there's a liver health score. And it may be, as we go into the future, that these sort of calculators and modalities really help us in clinic when we've got someone we're looking after in front of us with different comorbidities and different cluster comorbidities. So let's move on now to think a little bit about management and screening. So Giovanni, would you like to comment on when we've got 20, 30-minute clinic appointments, how should we assess screening and get the most out of our time with an individual that we're caring for?
Yes, Alan, I think it's very important what you say, that comorbidities will occur in people living with HIV as soon as age pass by. And so the point is that we must not just wait and diagnose comorbidities, but rather screen for comorbidities. Moreover, we need to think that if one comorbidities occur, according to the clustering principle, other comorbidities will come along. And so that is why guidelines, in particular, I refer to AIR's guidelines, recommend the fact that in all people living with HIV, comorbidities should be proactively screened, and proactive intervention should be driven in order to avoid the occurrence of new comorbidities. And so, of course, here what guidelines suggest is to screen for cardiovascular disease, for kidney disease, for cancer, for liver disease, for respiratory disease and diabetes. And so it's very important that we screen for comorbidities, we screen for multimorbidity, but also we screen for frailty that really express the vulnerability state of an individual. And actually, we know from Age HIV Court, a beautiful aging court in the Netherlands, that actually the prevalence of frailty is much higher and is occurring at an early age in people living with HIV when compared to control. And in fact, the progression to a robust, to a pre-frail and frail state is much faster in people living with HIV. And in fact, frailty is per se a reversible condition, but we also know that reversibility of frailty is somehow more difficult in people living with HIV. That is why I believe that an active screening and a proactive intervention in order to early diagnose, early treat, and possibly revert comorbidities and frailty should be pursued in the management of people living with HIV.
Thank you, Giovanni. So we've thought about screening, we've thought about these clusters. Let's think about best practice management, and both best practice management regarding polypharmacy and drug interactions and antiretroviral treatment. So Giovanni and Sharon, can you share some thoughts on best practice management?
So sure, Alan, as I might start, we looked at polypharmacy in our Change HIV cohort. And as Giovanni alluded to, there's often major relationships between polypharmacy, comorbidity, frailty, and falls. And in fact, we found that half of our cohort did have issues with frailty, and that many of these people had inappropriate drugs in their armamentarium, with almost 40% of them having moderate to high sedative burden. Well, the issue with this is that for those individuals who are frail, you then add a medication that impacts or that causes sedative effects. This is going to increase the risk of falls. And we, in fact, did find that correlation that people with frailty, high burden sedative drugs, did have more falls in the next 6 months. And then if you combine that with osteoporosis and other issues, it's going to lead to more fractures and more morbidity and mortality. So I think what this calls for is to make sure that we review the medications in our patients with multiple comorbidities, particularly paying attention to those with sedative properties. And in fact, in our cohort, we're going to be looking at a medication de-escalation protocol to see if that will improve the overall incidence of frailty and falls.
Yes, Sharon, and also let me add the fact that definitely we need to know how to manage comorbidities. We need also how to manage the prescribing in people living with HIV. And one important issue is to consider that antiretroviral may still play a role. Mind you, I want to be very clear that the antiretroviral that we manage nowadays are totally different than what we did in the past. And we know that the toxicity associated to antiretroviral that were somehow related to comorbidity itself, now it's definitely much less impact. And of course, now we've got safer drug. But still, there are some metabolic conditions that concern us also in contemporary use antiretroviral therapy. One of the issues that we are trying to address in the management of antiretroviral in people living with HIV is the issue of weight gain. The issue of weight gain refers to the fact that both in naive individual, but especially in experienced individual that switch to INSTI-based regimen, people may experience a clinically significant weight gain. This study is called the PASO double. It was presented in Munich last July, and actually it was a head-to-head comparison in people that were, yes, experienced to antiretroviral, but were naive both to BF-TAF or to dolutegravir 3DC regimen. They were randomized, and actually the two arms were compared with both antiretroviral efficacy, but also to metabolic concern. Of course, it was very much interesting to demonstrate that both the switching arm were completely effective. Actually, the effectiveness was above 9% in both the arms. But there was somehow a 1 kilo difference in weight increase that favor dolutegravir 3TC. Let me say, is this just 1 kilo difference that is clinically significant? No, I believe that is not this increase in 1 kilo more or less, but rather the proportion of patients that in fact reached a significant weight gain increase. That was 30% in the BF-TAF and 20% in the dolutegravir 3TC arm. So somehow what to conclude? Let me say, the PASO double is telling us that both BF-TAF and dual regimen based on dolutegravir are highly effective. That's good. But presumably, we need to be cautious on the use of TAF on the top of the INSTI whenever we want to avoid weight gain. And this is once again to say, well, we are responsible to the metabolic health of people living with HIV. Mind you, drugs are not the only driver, not necessarily the main driver, but we need to discuss this together with the patient in order to make the patient be aware that something in the lifestyle might change, need to be changed across the aging process. But on our side, it is our responsibility to be able to tailor antiretroviral regimen, not just because of virological efficacy, but also on metabolic health pathway.
Thank you, Giovanni and Sharon. So just before we finish, Sharon, can I ask you, we saw in Giovanni's slides earlier on the EACTS guidelines and screening. This can be quite difficult to implement because there's a lot of screening. What do you think are some of the most important practical aspects we need to be thinking about during clinic visits?
Yeah, and that's always difficult. And I think a little bit depends upon, who's the primary caregiver for this patient. And, in Canada here, we have many primary care physicians who have a lot of experience in HIV, and they do a lot of the care in their offices, where there's other patients that don't have a primary care physician, and we end up doing all of the work. So I think one of the first things you have to assess is, who's doing what, and making sure that there's good communication between the primary care, the specialty care, and the HIV clinic to make sure that all of the comorbidities are being considered. One of the things that we do for sure is we make sure we have a weight on every patient at every visit. As Gianvatti said, there may be some relationship to the antiretroviral drugs, but unless you have it documented, you don't know. Similarly, blood pressure, really important to do blood pressure. Now, maybe we don't do it at every visit with a young 20-year-old patient, but certainly as our older patients, it becomes important to measure blood pressure on a regular basis. I think it's important to review all of the comorbidities, what medications are being treated for the comorbidities and how well are they being managed and who is managing it. And then I think back again to the whole medication list to look at polypharmacy and to consider that. I think these are some of the important things that we do at each visit.
Let me also add, Sharon, what you are telling us is really that we need to focus our intervention in a patient-centered way. And so it's so much important that each individual is screened, and definitely the objective goes beyond assessment of diseases and goes into assessment of patient health, especially in the aging process.
And don't forget about those lifestyle interventions: smoking, drinking, food, exercise. All of those are important too.
Thank you, Sharon and Giovanni. So we have covered a lot. We have heard about comorbidities in people living with HIV, the clusters of these comorbidities, the real impact that this has on somebody, and heard about a lived experience. We've then thought about some of the underlying pathogenesis, both inflammatory processes and lifestyle factors, and it's been great to hear about recent interventional studies that are making differences. And I think the talk at the end, this really practical talk on what we can do in clinic, what we can do to help, has been very practical and helping to take this field forward. Giovanni and Sharon, I'd like to thank you for this very thought-provoking talks and great discussions. And I'd like to thank you all for participating in this activity. Now, please do give us a feedback, and please continue to answer the questions that follow and complete the evaluations. Thank you very much.
This program was presented by Medscape Education Global.